I'm delighted to be here tonight to speak to you all. As Michael mentioned, my name is Louise Brent. My background is as a nurse. I worked in University Hospital Waterford for 12 years as an orthopaedic nurse specialist. And then I joined the National Office of Clinical Audit 5 years ago to manage 2 clinical audits which focus on trauma care. So the Irish Hip Fracture Database, which you'll hear a lot about tonight, and the Major Trauma Audit is the other audit. But NOCA, as we call it for short, manages a number of national clinical audits. And I'm going to talk through in the presentation what a clinical audit actually is and what it does and how we use the information. So I suppose essentially clinical audit is about collecting information from charts, electronic records within the hospital system to measure care against a particular standard. And I'm going to use the hip fracture database tonight as my example to step you through a full audit from start to finish. And the purpose of doing clinical audit is to implement change for quality improvement. So to make things better for patients ultimately. To date, NOCA manages a number of different clinical audits. I've put up a few examples of the ones that we are currently working on. So heart attack, stroke, hip and knee replacement is one of our newer ones. Intensive care, which obviously was very topical due to the pandemic at the moment. So I'm going to move on and focus this presentation today on how and why healthcare information is accessed by public agencies for secondary uses. What are the benefits and risks of doing that? What safeguards have we got in place to make sure that this information is kept safe? And how does Ireland's approach to health information differ from other countries and other agencies? I just want to stress tonight I'm talking about NOCA, the National Office of Clinical Audit, as my example, but there are other agencies that would access data, and I'm sure you will hear from some of them throughout the course of this process. But on the screen there, you can just see there are some other examples of agencies that use the data. And the one that's probably most familiar to us all at the moment is the government portal that's using health data at the moment to keep us all updated about what's happening in the pandemic. So I suppose to make it clear to everybody what a clinical audit does and why we do it, I'm going to just step through the cycle that we use for clinical audit, and I'm going to use hip fractures throughout just to make it a bit easier to understand. So the topic that you're going to audit should have a subject that has a good number of cases related to it. So for example, hip fractures are a very common injury in Ireland and in the world. So there's over 3,700 occur every year in Ireland. The patients tend to be older. The average age is 80, and they have a very complex clinical pathway. So if you imagine, they generally have a fall at home. They're brought in by ambulance into the emergency department. They'll then have to have x-rays. They'll go to theatre to fix their hip fracture, and they'll meet lots of different clinicians along the way. They'll have an anaesthetist, an orthopaedic surgeon, a geriatrician, and then they'll be seen by nurses, physios, OTs. So by measuring the process of care, we're getting information on how the whole service is working to care for older people, to care for fracture patients. So the information we get back is really beneficial. You have to have something to measure against with audit. So with hip fractures, there has been lots of evidence produced from many countries, Ireland included, about what the best things are to do when you have a hip fracture patient come into your hospital. So ultimately, the best thing to do for these patients is to fix their hip fracture so that they can walk again and get back on their feet. But there's lots of other standards as well. And as we go through the presentation, I'll elaborate on some of them in more detail. But the whole purpose of audit is to measure against standards. And when we collect that data, then it's important to look at it in detail. So one of the things I would caution about clinical audit is it's only as good as the information you get, first of all. So if you only got 50% of the data on all the hip fractures, you couldn't really make any robust assumptions about what that's telling you, because the other 50% could tell you something completely different. So to be assured that we are getting enough information and to getting the right information, we have thresholds of data coverage, we call it. So we would have an expectation that at a minimum, we'd have to receive about 80% of the data to rely on it to make decisions about it. In Ireland, our hip fracture database has been going for nearly 8 years, and we have 99% of the data captured each year on all the cases. So we have a really, really good picture now of what's happening for our hip fracture patients in the hospital. We turn the data into reports. We try to make the data as clear and as easy to understand for our clinicians and our hospital staff, particularly, who we send these reports back to then every quarter. So 4 times a year, we will send these reports back to the hospitals and say, this is how Waterford are doing. This is how many hip fractures they've had. This is how many got their surgery on time. This is how many of them were seen by the right people in the right order, all that sort of information. And where there are gaps or areas for improvement, the local clinicians that are in the hip fracture group can come together and say, okay, this is what we need to do to get more patients to theatre on time, or to get, less people developing pressure ulcers, or whatever the case may be. And then we expect our hospitals and our clinicians and our teams to make those changes or work on those changes, and then come back around that circle again to evaluate how those improvements have made a difference. And this is an ongoing cyclical process that goes on all the time. Collect the data, look at the data, measure the care, and send back the information to the hospitals. So the benefits of having this type of information have multiple facets, I suppose. And I wanted to just try and give you some examples of how this information has benefited us at a national level, at a local level, and more broadly to the public and to the patients. So I'm going to just share with you first some of the national impacts that the hip fracture audit has brought about. So when we started collecting the information on hip fractures, we discovered that 1 in 4 patients in Ireland were actually being brought in to a hospital that didn't provide an orthopaedic service. So they couldn't do anything about their fracture. And it's easy to identify somebody that has a hip fracture by our ambulance personnel. Our paramedics can easily, expect that they are suspect that a patient may have a broken hip, and therefore bypass the local hospital, which has no orthopedics, and bring them to the hospital that can ultimately fix their hip. So it may be a slightly longer journey, but it's direct and it's cutting out that second hospital transfer. So since we published that data a number of years ago, the National Ambulance Service worked with us, and now they've created a system whereby hip fracture patients, if they're suspected, can go straight to hospitals that can operate on them ultimately. The second big development was, again, I mentioned earlier, hip fracture patients tend to be older patients. They're generally over the age of 80. And, on top of coming in with a hip fracture, they also have to undergo surgery, and they also have to cope with their existing medical condition. So most 80-year-olds, as sprightly as they may be, will be on possibly a number of tablets and may have comorbidities that also need to be managed. And orthopedic surgeons are fantastic at fixing bones, but they're not skilled in managing multiple medical conditions. And that's why we need our geriatrician colleagues to look after these patients with the orthopedic doctors. So in Ireland, when we started this audit, there was no ortho-geriatricians at all. There was no geriatricians specialised in orthopedics in Ireland. And through the years, and through having the data, we have managed now to justify to our health system that we need these specialists within our hospitals to care for these patients with fractures. And I'm really delighted to say that nearly all our hospitals now that operate on orthopedic or hip fracture patients have an ortho-geriatrician. And in addition to that, more recently, we've now seen advanced nurse practitioners who specialise in orthogeriatrics being appointed as well. So that's been a really big achievement for us.
Sorry, Louise, you just have a minute left there.
Oh God, sorry. And sorry, the other thing was about we've generally seen all the standards of care improve. The impact locally, again, has been on the teams using the data for quality improvement and making a difference at a local level. New appointments, like I've mentioned, new equipment, And we've developed this Golden Hip Award that we give to the hospital that has the best performance in all the standards each year, which is a really nice thing. The best practice tariff, I want to just explain very briefly, is a monetary award that's given back to the hospitals per case that meets the standards. And the money goes directly back into the trauma service to be used on patient care and improving patient care. So some of the money, for example, would be used to buy new patient comfort equipment, new machines, new mattresses, new to do training programs, to send staff on education, etc., to again improve that patient care. Some of the other benefits of having this information has been that we've been able to use it to design injury prevention information. For example, most hip fractures occur at home from a low fall, and we've used the data to dig into to see how are so many people falling at home and what is it we can do to highlight the things so that they avoid having these falls in the first place. We work.
Sorry, Louise, you're out of time now. So is there anything you want to say to kind of sum up your final slides?
Yeah, absolutely. We do work very closely with patients involved in the audits. That's very important to say. And we do have processes when we're designing these audits. We do that with privacy in mind. So we only collect the minimum amount of data. Any patient sensitive data is not shared with us in NOCA. It's kept at the hospital level, and all the audits that we manage are GDPR compliant. So everything we do is with keeping patient privacy and patient data absolutely safe as possible. And we collaborate internationally with other hip fracture registers and similar audits to learn from each other and to use our information for research. So a lot of our standards in Ireland, we have verified their validity through our own data. So as just to follow on from what was mentioned by June, it must have been mentioned yesterday, we do actually use our own data to develop our own standards as well, which I think is very important. And so sorry for running on a little bit, but I hope I got my point across, and I look forward to your questions.
That's